colleague, friend, Salvatore Calabrò.
Good afternoon to everyone. Thank you for inviting me to this interesting international meeting. And now, how Dr. Leonardi says, I'm going to show you the technical feature and the clinical data on our Italian network on teleneurorehabilitation. As Leonardi says, the neuroscience network is mainly aimed at improving the translational research in the neurological field by sharing goals and protocols. That is the main aim of our network. And why we concentrate on telerehabilitation? Because we know that neurological disorders represent one of the leading causes of disability worldwide, with a high burden for healthcare service and also for the caregiver. So the aim of this group was to identify new diagnostic and therapeutic pathway for a better rehabilitation. We know indeed that many healthcare systems recommend an early discharge of this patient, especially those affected by stroke, for example, not providing them for the adequate rehabilitation because of the high cost of the technologies, or for example, like in the southern Italy, because we are distant from the hospital, so we have many geographical barriers, or because of the disabilities. So innovative local and national initiatives aimed at improving a sustainable rehabilitative pathway are needed, and this is what the Minister of Health asked us. And the answer maybe is telerehabilitation, that here I simply define as a way to provide rehabilitation service at home through information and communication technology, because maybe is able to reduce hospitalization time and the related cost, enable the patient for rehabilitation at home, and is also able to reduce transfer cost for patient and therapists, as well as the caregiver burden. So, if we quickly look at the evidence concerning the role of telerehabilitation, as Italy, we participate in these interesting two European studies using the home care activity desk that have demonstrated how telerehabilitation was able to improve upper limb function in patients affected by stroke, traumatic brain injury, and multiple sclerosis. Also, our group provided some evidence showing that the telehealthcare system can be considered a valuable tool for the care of the elderly or patients affected by different neurological disorders, living either at home or in nursing home, allowing for care continuity. And thanks to the Ministry of Health, our institute, and the Sicilian government, we have done some years ago a pilot study that was aimed at follow the patient affected by stroke from the acute phase to their home by means of the rehabilitation system that we will see later. Indeed, as you can see, the patient is followed by the stroke unit by using this particular device. Then it can be followed to the intensive rehab unit, to extensive one, and then at home, providing the patient with exercise that are continually adapted to the patient need and above all to the functional status. This was just a pilot study where we aimed to evaluate the feasibility and usability of the system, but we don't have many data concerning the patient. Indeed, as some of you this morning told, really, if we look at the systematic review, there is no clear evidence concerning the role of telerehabilitation in improving motor function, especially in patients affected by stroke, or cognitive function in patients affected by dementia, or, for example, the group from San Camillo shows that concerning motor recovery, maybe telerehabilitation doesn't work as is. But the problem is maybe related to the low sample size and also the criteria of inclusion. And it seems that there is a little evidence concerning the improvement in fatigue, quality of life, and activity of daily life in patients affected by multiple sclerosis. So, as there is no clear evidence for the effectiveness of telerehabilitation we have no standardized protocol worldwide, and there is, above all, no evidence of the cost-effectiveness ratio for teleneurology and telerehabilitation. This project was aimed at evaluating if the clinical efficacy of telerehabilitation was at least not inferior in comparison to standard treatment as per motor and cognitive function and activity of daily living in patients affected by neurological disorders. But we also aimed at evaluating the cost-effectiveness analysis. Many works say that telerehabilitation probably works, but it doesn't work better than normal rehabilitation, but maybe it costs less. So if we can spare some money, it could be interesting for the healthcare system. Then we want to define common rehabilitation protocols leading to national guidelines to plan new rehabilitation pathway, and to develop Irccs network, an Irccs network common platform where we can store the data. And so these are the 18 Irccs that participate in this pilot study. And this is the technology that we are using at the moment. As you can see, there is a national server that we will see later. Then we use in hospital devices with regard to the VRRS station and the HOC, and then the other devices that can be used at home. And in particular, the protocols that at the moment are ongoing are using the virtual reality rehabilitation system in the three forms, because we have the EVO1, that is a medical device that can be used in hospital, also in the acute phase, the VRS-TR, that can be used both at home and in hospital, and then for home, we use usually the tablet with the different devices. And the system has a vast library activity with multisensorial exercises that are clinically organized in validated modules involving neurologic, cognitive, logopedic, stabilometric, orthopedic, cardiorespiratory ones, and allow the therapists to create personalized exercise that can be continually adapted to the patient need. And as Dr. Agostoni told this morning, we can use the system into different modality, online and offline. Online with the therapist and the patient that work in a dedicated audio-video teleconference, and offline the patient made himself the exercise that then can be remotely evaluated by the clinician or the therapist. And if you can. Okay. And this is our workstation. This is the telecockpit where we can follow the patient. The patient works at home with the supervision of the therapist. And thanks to this kind of device, we can follow more patients at the same time. A therapist is able to follow more patients. This is a key one. This is a sensor that is able for the upper limb rehabilitation. And this is an example of cognitive rehabilitation made directly on the neuropsychologist and the patient. Motor and cognitive exercise can be used in two modalities. 2D exercise, where the patient may interact with the objects and the environment through the touch screen or using a mouse-like interaction system. 3D exercises is when the 3D non-immersive virtual scenarios are reached thanks to a magnetic tracking sensor that is generally placed over the end. And concerning cognitive rehabilitation, we have at the moment more than 50 exercises covering most of the cognitive function, memory, attention, language, spatiotemporal orientation, and so on. Whereas, generally speaking, all the tasks are organized like pick and place, ordering, sequential activities, or reaching, balance, and breathing exercises. And each exercise provides the patient with an online and after completion acoustic feedback following the principles of the operant conditioning. And here there is, if it starts, another video just show how the 2D virtual reality is used. Just touching the screen is a simple puzzle. This is an example of balance exercise that we can do. This is the WRS Evo, and we use it, of course, at home to improve the function before discharge, and then with the other devices, they can continue the rehabilitation at home. And this is just an example to how it can be used by the sensors. So the patient has the idea to move in the space. That's the reason why we call it 3D non-immersive virtual reality. And so why virtual reality works? Works because we know that it allows the user to interact with this computer-generated environment that is able to enhance patient motivation, enjoyment, and also to perform those activities of daily living that are not too dangerous to perform in real life. And exercise in this virtual environment provide the patient with the knowledge of results and the knowledge of performance that are, of course, important signals for the augmented feedback to improve both neuroplasticity and then motor and cognitive recovery. And which is the state of the art and our future direction? The project started on June 8, 2016, the 9 years that started this interesting work. We have done the cloud platform, the WRS data repository that is called WRS Server Manager, where every Irccs is able to connect with the central platform by using a Windows Communication Foundation that is encrypted and safe mean for communication to avoid data spreading. And at the moment, we started with 4 protocols, and I will briefly give you the first result that we have analyzed just in the last days, because the project is coordinated by our center that is involved mainly in the health technology assessment and cost effectiveness analysis. And we have started with the evaluation of 4 of the main neurological disorders: stroke, Parkinson's disease, dementia, and multiple sclerosis. This study on stroke is aimed at evaluating the feasibility and effectiveness of the system in the motor and cognitive recovery. This is a pilot open-label multi-center study. We expect to enroll 100 patients undergoing 20 sessions of treatment with an assessment involving different functions at baseline and the end of the training. And how you can see, at the moment, we have completed the enrollment of 25 patients with a mean age of 61 years. And the system had a good feasibility. And how you can see also if we have just an experimental group, so we can generalize our result. We saw anyway that the patient improvement as per Fugmeyer total score. The second pilot study was on Parkinson's disease to evaluate the feasibility and effectiveness of the system in the functional recovery and quality of life in patients with Parkinson's disease as compared, in this case, with usual care. This is indeed an assessor-blinded randomized clinical trial where we expect to enroll 110 patients undergoing 40 sessions of treatment, and the assessment is done at baseline and at the end of the training. And in this case, we have enrolled 42 patients, 20 in the experimental group. At the moment, concerning one of the main outcome measure, PDQ-8, we don't have a real improvement, but just a trend in the experimental group. This is concerning multiple sclerosis. Also, in this case, we evaluated the effect as compared to usual care. Is also an assessor-blinded randomized clinical trial where we expect to enroll 96 patients undergoing 30 sections of treatment and the assessment at baseline at the end of the training. And these are our preliminary data. We have enrolled 36 patients with at baseline no different in age, gender between the experimental and control group. And how you can see, there is a significant increase in the quality of life related just to the perception of the physical component in the experimental group, the group undergoing virtual reality. And this is the last where we are aimed at evaluating the effect of the system using a multidisciplinary approach in the cognitive recovery of patients affected by mild cognitive impairment, primary progressive aphasia, and behavioral variant of the frontotemporal dementia as compared to usual care. At this moment, we have enrolled just patients affected by MCI, but the study design is a bit more complex than the precedent one. Indeed, we have 3 groups: inpatient standard rehabilitation, patient undergoing virtual reality in hospital virtual reality followed by virtual reality coupled to telerehabilitation, and then virtual reality followed by standard care. We have planned to do different evaluation, but at the moment the data are available just for start at the end of the training. And we can see that here we have enrolled 27 patients, and only for quality of life we have a significant improvement in the group undergoing virtual reality in both clinical setting and home. So what we have in progress? Of course, we want to involve other Irccs and maybe other research institutes that have more advanced technology, but we are carrying out different protocols involving neuromuscular disorders, spinal cord injury, and severe acquired brain injury. To this end, we are conducted a study that has been funded by Italian Ministry of Health in collaboration with San Camillo and the University of Messina concerning the role of telerehabilitation in patients affected by severe acquired brain injury. And what we expect? We expect from this protocol or this work a reduction of the territorial healthcare service disparities, of the admission in specialized structure, because patients can be usefully treated at home or, for example, following an hub-and-spoke model. The hub, by means of telerehabilitation, can improve the rehabilitation care also in the more peripheral hospital. And we expect, of course, a reduction of direct and indirect costs related to rehab. And we are going to finish our work writing a consensus paper or national telerehabilitation guidelines. And just to conclude, we know that telerehabilitation may increase the intensity and duration of rehabilitation programs with a potentially good cost-effectiveness ratio, maybe in patients affected by more severe disability, but one may concern on the fact that patients may lose the real contact with the therapist, and someone says there is a risk of isolation. And we are also wondering about the acceptance and usability of such innovation technology, even if, especially in the elderly, even if with our pilot study, we found that also the elderly have a good usability of the system. And the most important thing is to find how telerehabilitation candidates should be selected. Sensory motor and severely impaired comprehension may affect, for example, the training. And to conclude, I just want to read this sentence by Professor Caltagirone, who says that telerehabilitation is a work-in-progress field where there is the opportunity to develop a lot of interesting paradigms. It is not a new therapy in need of empirical validation, but more simply a new channel for administering whole therapeutic intervention. And thank you for your attention.
Thank you, Dr. Calabrò. I don't know if there is some question. Oh.
Thank you very much for a very, very interesting presentation, and I'd like to congratulate you on a fantastic network. That's really terrific. This is probably more a comment than a question. One of the points you made there was about one of the perils, that there's the potential for people to feel isolated via tele. I think if we try to, that's possible, but I think one of the advantages also of tele is that people can start to develop a peer support network through that. And certainly we found in a couple of our studies where people have made, when the group therapy work, where they've actually made connections with people that they've been involved in with group therapy and continue those associations. So I think there is a very positive spin there that you could, people through, whether it's through your platform or how it might work, but people could actually develop peer support. So people with similar disorders could, and their families could talk to each other. And I think that's probably a very, very valuable way to use tele as well. Okay.
Thank you, and I agree with you. I just write in the last slide the pro and cons and what in the published paper there is not my idea, because, for example, we found that in the elderly, also without any kind of illness, the fact that someone called them to speak with them, just to do some psychological support, is more than isolation. But I just write down this for scientific evidence, because someone says that it's possible.
Hi, Calabrò.
Hi.
I think compliment to you for wonderful work, but I think compliment goes to the Ministry of Health.
Of course.
What I realize is that unless the project is being directed and supervised by the Ministry of Health, it is not going to take off. And this is the biggest problem what we are facing in developing countries like India and others. It's because the projects are either done by the private institute or the individual, and that's the reason it is not at the national level. And I think this is a very important point, and what you have been shown is that if this kind of projects has been taken by the ministry and they're pushed forward, and it reaches into the, to the mass. Some experience, I just wanted to ask you one question. A little bit of experience of telerehabilitation, what we got is the caregiver burden is increased. So what we realize is when we ask the questions to the caregiver, they said that our burden has increased compared to the before when we are doing the telerehabilitation, because probably in India, because of illiteracy, elderly people are not very friendly with the computer and telephones. Maybe somebody has to sit or stand with the patient. So what's your experience about this? Because the caregiver has already been burdened to take the work of the patient, and now they feel that if it is there. So maybe this could be one factor which might hinder our good result in the future.
We are not still evaluated the caregiver burden, but in our experience, we saw that there are different positions in this sense, because there are some caregivers that need, for example, consultation and support. I mean, for example, patient with dementia, sometimes they have difficulty to reach the doctor, and they can, for example, ask for help by means of telerehabilitation, also in simple things, how to behave when the patient became aggressive and so on. And on the other side, sometimes they don't like to stay there, it's true, to stay there, and maybe it's better in patients that are impaired but somehow able to do the exercise by themselves, because some caregiver doesn't like. Yes,
exactly.
You are true on this.
Thank you.
Yeah.
Hi, I'm Sabrina from Kuala Lumpur. I echo what Professor Newman said. I'm more interested in timeline from the time that you guys are rolling out what you want to implement in the community. So how long did it take for your center to make sure that it is actually done at the caregiver level at home?
How?
Have you actually done it, or it's just research?
No. We didn't have.
Not yet.
No, not yet.
Okay, so
Maybe-
how do you like project? How long will it take for you guys to actually implement it, and so that the caregivers do it on a like everyday basis, not just for research but actual practice?
Just to, but I think more like six months, 1 year.
We
6
started
1
in 2016, isn't
Yeah.
it?
We started, but we lost. I can say lost, but just 1 year to share the platform. We had many problems with policy of data sharing. You know that we have a law on privacy and data, and we have to work hard before starting the enrollment, because who is the owner of this data? Is my Irccs, is the owner of the Irccs, and so it was really a problem. We lost about 1 year to this. Yeah.
I just refer to what Professor Shural said earlier about government's involvement. I fully agree with that. But at the same time, how do we get government to be involved in a project? Does it start with government being convinced by a lot of work being done locally, or is it just the government has thought that themselves that would be the way forward and devolves it to the ground?
Maybe it's better if Dr. Donardi answer, because I think it was his idea and push us for years to share opinion, to share protocols, but it's better if you...
Well, not my idea, it was a political mandate, okay? So what the minister said, I want these networks to work, and so we started. Of course, this is peculiar for Italy for two reasons. One is because we have these research hospitals which are peculiar to the NHS. So since we have an NHS, we have these institutes. And the fact that the minister is so much committed to the function of the national system makes it possible to implement these networks. There is an ongoing talks in Italy to have, for example, a research agency. One of the problems we see in the National Research Agency is that it will go out of the responsibility of the various ministries, and it will be a research. But this puts it out from the national system or the agricultural field or the environment field and so on. When research is linked to the sectoral policy, then it is possible to implement such projects, because of course we have the strength of the money we put in, but we have the strength of the hospitals. So when you put together these two things, then it works. And of course it was not easy at the beginning because money was always the same. We have the budget, and we asked our institutes to work together with the same budget. So there was no additional budget. In the first meeting of this network, the question was, okay, we work together. Where's the money? And I said, it's your money.
Yes.
You start working together, and money will come. As a matter of fact, this year we had 10 more million euros for the networks. We also are carrying two projects, one for 5 million for CAR T cells with the oncology network, and one for cardiovascular primary prevention, which is other 5 million this year, 5 million next year. These were granted directly by the Parliament because they wanted Irccs to run these national projects. So once you work together, once you show that you can work together for the people, then, in my opinion, money comes. when you work the way around, you say, okay, give me money, I will do something. That's the way it does work. Okay, so this is the strength of these networks.
Other questions? No, okay. Thank you. Many thanks, Dr. Donardi. Many thanks, Salvo.